Well, that unpublished data will have to undergo some peer review before we really see it. But I'm going to talk about the fact that I think these rods are expensive and really not significantly better than what I can do with some standard instruments, albeit archaic. I will say by disclosure, I was involved in the development of some software for preoperative planning as well as patient-specific rods. So what I think is resolved in our debate here is that patient-specific rods really are not cost-effective, and the evidence for this is 6 points in 6 minutes. So first, there's a myth that the radius of curvature of a rod has anything to do with the angle of the segments involved. Secondly, the complete neglect of the coronal plane in our current patient-specific rods. And I think patient-specific alone is a misnomer. This really ought to be surgeon-specific rods rather than patient-specific. The burden of proof for cost-effectiveness simply hasn't been met, and I'll show you that. And the miscalculation of parameters is something that we've just recently been informed of, and there may be some liability involved in miscalculating these parameters. And finally, I think what Peter's really doing is willfully destroying the art of spine surgery. So again, basic geometry 101. Rod contour is a radius of curvature that's really measured in length. And angular measurement in degree is completely disassociated from the rod contour by our polyaxial screws. So if you truly want to have a association between rod contour and your lordosis, you've got to use fixed axis screws. And very few of us in deformity surgery are using fixed axis screws at every level. So, and this is something that historically, Mike Riefers pointed this out, that historically, before we had multi-axial screws, indeed, the rod had to be perpendicular to the screw, and this is where bending the rod really broke the rod, and this is part of the development of multi-axial screws, is to disassociate the angle from the rod contour. So again, unless we're going to use fixed axis screws, which we're not, in complex deformity certainly, then there's a clear disassociation between rod contour and the angle. This is an actual advertisement for pre-contoured rods. So you see this very complex single-level deformity here, and I'll admit that it wasn't Peter who was the surgeon perspective given on this, but it was another notable surgeon. And in this pretty straightforward case, the argument for a patient-specific rod makes no sense to me at all, yet the sponsor paid a lot of money for this and suggested that in this very straightforward degenerative case, from 4 to 1, I would say that really what determines the contour is the anterior spine surgery, certainly not a percutaneous rod placed posteriorly. And in fact, you can see the angle between the S1 screw and the rod suggests that there's no association between rod contour and the angle from 4 to 1. So again, this disassociation is just mythical. Next is the complete neglect of the coronal plane. So some of the early work that I actually did with Metacrea, looking at the coronal plane or looking at pre-contoured rods, this was actually a rod that was bent for me, subsequently discarded, and I used a rod that I created intraoperatively, but that is an actual rod that was created in the early days. And so here's an example of a patient who had prior surgery for cervical myelopathy, subsequently came to surgery with one of my partners for his idiopathic deformity. You see a combined sagittal and coronal deformity, and my partner did a really nice job of determining the sagittal alignment here with a planned anterior and posterior approach. The observed outcome really didn't match the plan very well, either in the sagittal plane, but even more importantly, nobody even looked at the coronal plane. So you see postoperatively here the dramatic residual coronal plane deformity. Next is, I think perhaps most important, is the misnomer of a patient-specific plan. I think that plans are really surgeon-specific. And ultimately, we're the ones who are accountable for the outcome of care. And the modeling, what I often do actually is in real time is model alternative strategies to see what might give me a better correction. So here's a case of mine that's upcoming where I've modeled what would an A lift from 4 to 1 look versus to posterior 10 to 1. What would a L4 PSO look is the second one. And the final one is, should I go from T10 to S1? Now, the company will make any of these rods for you, but ultimately you're the one who's got to be responsible for determining, well, what's the alignment that I want? And because any of these will be created for you if this is what you request. And the real problem here with regard to the measurements is how many people got this letter. So this is in my inbox on December 3rd, 2024, so just a couple months ago. I actually got another one just yesterday. I'm not sure why. I haven't opened it yet. But dear healthcare provider, this is to inform you that the software anomalies may have errors that resulted in incorrect calculations. So Peter, this is the kind of stuff that's going to get you behind bars. Finally, the basic requirement for cost-effective new technologies. So ultimately, a new technology's cost-effective has got to have some incremental benefit with, that justifies the change in cost. So what am I getting for my $1,200 extra per rod, as well as $1,000 of surgical planning fee? What am I getting for that $3,500? And I would suggest to you, nothing. In fact, Peter would agree. So Peter looked at this in the cervical spine, looking at the impact of preoperative planning and patient-specific rods in the cervical spine on postoperative alignment and outcome. And what he fundamentally showed is there was no difference in cervical lordosis, no difference in cervical SVA, no difference in T1 slope. However, there were significant differences between what was planned and what was observed in terms of the outcome, meaning the plan didn't match the observation very well at all. This was shown, this is a slide that Greg Mundus actually gave me, looking at another study, 20 patients who underwent at least a 4-level fusion with a patient-specific rod, single institution study. And what they showed here is that there's actually no correlation at all between the preoperative plan and what was seen at 2-year follow-up. So for example, preoperative SVA, the plan for SVA was to be within 30 millimeters. They ended up basically having postoperative parameters that are very similar to the preoperative parameters. So a real mismatch between plan and outcome. Then a couple of systematic reviews that again confirmed that there's no real value to these patient-specific rods. In this systematic review of 7 studies, 304 adult deformity patients, only 2 out of 7 patients actually had a positive association between our sagittal parameters and outcomes. And what they showed is in these studies, the significance of the results really varied greatly. Another, this is actually a narrative review, looking at no difference in revision surgeries and concerns about expenditures and cost effectiveness. No difference in mechanical complications, including PJK between the pre-bent rods and the historical rods. So ultimately, I think optimally performed surgery involves a surgeon determining the appropriate alignment, not some industry-mediated mismeasurement of parameters. I think an intraoperative assessment of observed alignment with the ability to make some appropriate adjustments is really critical. So accurately figuring out your alignment intraoperatively and adjusting that rather than just following blindly a rod that actually gets bent oftentimes in more stiff deformity. I think if we're going to be cost stewards, we need to think about investing in technologies that make a measurable difference in outcome. And I've shown you that there's no consistent measurable difference in outcome using these patient-specific rods. And finally, we want to preserve the art of spine surgery. And I think that using these tools, using an accurate intraoperative assessment of alignment, I can get optimal results. In contrast, Peter perhaps follows the words of Oppenheimer and has become death, the destroyer of art. So thanks for the opportunity to participate.
All right, that was a great debate, very entertaining. So looks like Sig won that one. Sorry, Peter. I want to just thank all of our combatants today. This was very entertaining. I think Dave Cahill would be very pleased with how these sessions are turning out.